Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. So here's a question most employers have never asked themselves. How much is your employee's medical debt costing you? Not how much are you paying in health insurance premiums, not how much your deductibles are, but how much are you paying because your employees are carrying medical debt they can't afford? The answer's going to surprise you. For a typical 100-employee firm in Southern Oregon, the number is about $500,000 a year, $512,736 to be exact. And most employers have no idea. Today, we're talking about the hidden business costs of medical debt and why the systems we've built to deal with unpaid medical bills are actually making everything worse for everyone involved. Employers, hospitals, patients, everybody loses except the collections agencies. Let's start with what employers can see. When an employee's medical debt goes to collections and results in wage garnishment, there's paperwork. HR has to process it. It takes 3, maybe 4 hours per garnishment. You've got payroll system adjustments, maybe some legal review if the employee contests it, ongoing tracking, remittance to the collections agency. For a 100-employee firm, you're looking at maybe 6 to 8 garnishments a year related to medical debt. That's about 24 to 32 hours of HR time. Call it $2,000 to $2,500 in direct costs. Okay, annoying, but manageable, right? Then there are 401(k) hardship withdrawals. Employees with medical debt often request hardship withdrawals to pay their bills. More paperwork, review and approval process, 2 to 3 hours per request. Fiduciary review, documentation, tax reporting complications. Another 8 to 12 requests per year, another couple $1,000s in administrative costs. So direct costs, you're looking at maybe $5,000 a year for a 100-employee firm. That's visible. That's on the books. But here's what's not visible. Here's what doesn't show up in any line item anywhere. Absenteeism. Employees with medical debt use more sick days, not because they're lazy, because medical debt creates stress. Real physiological stress that disrupts sleep, triggers anxiety, exacerbates existing health conditions. And here's the perverse part. Because they're worried about generating more medical debt, they delay care. So when they finally do get sick, they're sicker. They're out longer. The numbers. Employees with medical debt miss an additional 6.2 days per year compared to employees without medical debt. That's not total sick days. That's additional days caused by the debt itself. For a 100-employee firm, where 19% of employees have medical debt, that's 19 people, you're looking at about 118 extra days of absence per year. At $280 per day in lost productivity, that's $33,000 annually. But wait, it gets worse. Presenteeism. That's the term for when someone shows up to work, but they're not really there. They're stressed, distracted, overwhelmed. They're fielding collections calls. They're trying to figure out which bill to pay. They're lying awake at night doing math that doesn't work. Research shows employees experiencing moderate to severe financial stress have productivity losses of 12 to 28%. And employees with medical debt, 68% report moderate to severe financial stress. Let's be conservative. Say 18% average productivity loss on about 95 days per year for those 19 employees. That works out to about 300 to 25 days of lost productive capacity. At $280 per day, that's $91,000. We're now at $124,000 in absenteeism and presenteeism alone. And we haven't even gotten to the big one yet. Turnover. Employees with medical debt are 75% more likely to leave. They're looking for better benefits. They're stressed and burned out. They're taking jobs that pay a little more because they're desperate. For our 100-employee firm, medical debt causes about 2.3 additional employee departures per year. And the cost to replace an employee? Recruiting costs, training costs, lost productivity during vacancy and ramp-up time? About $48,000 per person. That's $110,400 per year in turnover costs attributable to medical debt. Then there's engagement. Employees with medical debt score 18 points lower on engagement surveys. Lower engagement means lower discretionary effort, more errors, lower customer satisfaction. The impact is equivalent to losing about 3.4 full-time employees worth of productive capacity. At an average salary of $58,000, that's another $197,000. Add it all up. Absenteeism, $33,000. Presenteeism, $91,000. Turnover, $110,400. Reduced engagement, $197,000, plus direct costs, $5,000, total, $436,400. But we're not done. Workers' comp claims. When employees have medical debt, they're afraid to report minor work injuries. Why? Because they're terrified those injuries might get classified as non-work related, and they'll get stuck with personal medical bills they can't afford. So they don't report that repetitive stress injury early when it could be treated cheaply. They wait. It gets worse. Then they file a workers' comp claim, but now it's a major injury instead of a minor one. Early treatment of a minor work injury, about $4,200. Delayed treatment after it's become serious, $18,400. The difference, $14,200 per claim. For a 100-employee firm, medical debt fears cause about 2 to 3 delayed workers' comp claims per year. That's another $35,500. And finally, healthcare utilization patterns. Employees with medical debt avoid preventive care. They skip their annual physicals, they don't get that mammogram, they put off the colonoscopy. Why? They're afraid of bills. So they eventually need emergency care. And emergency care costs 8 to 12 times more than preventive care. The result, higher group insurance claims, which means higher premiums at renewal, about $41,000 higher per year for our 100-employee firm. So let's add it all up. Direct costs, $5,000. Absenteeism, $33,000. Presenteeism, $91,000. Turnover, $110,400. Reduced engagement, $197,000. Workers' comp, $35,500. Premium increases, $41,000. Total, $512,900. A 7-to-1 amplification effect. And most employers have no idea because these costs are invisible. They're not categorized by cause. Absenteeism gets tracked, but not the reason for it. Presenteeism doesn't get tracked at all. Turnover gets measured, but nobody connects it to medical debt. Premium increases get blamed on market trends. So employers think medical debt is someone else's problem. Meanwhile, they're already paying for it. Heavily. Okay, so you might be thinking, don't hospitals have programs to help people who can't afford their bills? Charity care? Yes, they do. And those programs are well-intentioned. And they are doing great work. But they're not solving the problem. Let me explain how charity care works. Nonprofit hospitals, which includes most hospitals in Southern Oregon, are required to offer financial assistance programs. It's part of their tax-exempt status under federal law. They have to have a written policy. They have to publicize it. They have to offer it to qualifying low-income patients. Sounds good, right? Here's the problem. There are no federal standards for what counts as qualifying. No requirements for income thresholds. No requirements for how easy or hard the application process can be. No requirements for processing timelines. So every hospital does it differently. Asante Health System offers charity care to families earning less than 200% of the federal poverty level. That's about $60,000 for a family of 4. Providence Medford goes a bit higher, 300% of poverty, about $90,000. Three Rivers in Grants Pass is at 250%, about $75,000. Now here's the thing. The income distribution of people carrying medical debt in Southern Oregon doesn't match these thresholds. 28% of medical debt holders earn below 200% of poverty. They'd qualify for full charity care at most hospitals. Another 34% earn between 200 and 300% of poverty. They might get partial assistance at some hospitals, but that leaves 38% earning above 300% of poverty. They make too much for charity care, but they still can't afford their medical bills. So right off the bat, charity care doesn't help 72% of the people carrying medical debt. They're not poor enough to qualify, but they're not wealthy enough to absorb the cost. But even for people who do qualify, there's another problem. Most of them don't know it exists. Survey data shows only 34% of patients are even aware that hospitals offer financial assistance programs. And of those who are aware, only 18% have ever applied. Why not? I didn't think I'd qualify, or it seemed too complicated, or I didn't know how, or I was embarrassed. The result, only 6% of eligible patients actually apply for charity care, and of those who do apply, 42% get rejected. Not necessarily because they don't qualify, but often because they can't provide all the required documentation. Last 2 years of tax returns, 3 months of pay stubs, bank statements for all accounts, asset documentation, proof of expenses, household composition verification. For a family that's financially unstable, maybe self-employed, maybe working multiple jobs, maybe just not good at keeping organized records, this is overwhelming. But let's say you make it through. You qualify, you submit everything, you wait. Here's one scenario of the timeline problem. Week 1, your medical bill arrives. Payment due in 30 days. Week 5, bill is overdue. Hospital collections process begins. Week 8, you finally learn about charity care. You submit your application. Week 12, bill gets sent to outside collections. That's the 90-day threshold. Week 14, your charity care application finally gets approved. Week 15, hospital recalls the bill from collections. You're forgiven. Great, right? Except your credit score already got hit. The collections agency already reported it to the credit bureaus. You already spent weeks getting threatening phone calls. The process can fail to prevent the harm it's supposed to address. And even when charity care works, it often doesn't cover everything. Here's why. Charity care is hospital charity care. It only covers the hospital facility fees. You could be charged for non-hospital services like the radiologist who read your CT scan, the lab that processed your blood work, or a consulting specialist. Those are separate entities, separate billing, and most of them don't offer charity care at all. Some percentage of your debt could still be there. In Southern Oregon last year, hospitals provided about $30 million in charity care. That sounds like a lot, but total medical debt in the region is $52 million. And that charity care figure includes uninsured patients, not just underinsured people with high deductibles. It includes the bills that didn't involve separate physician billing. If every eligible patient actually applied and got approved, hospitals would need to provide an additional $18 to $24 million in charity care. They'd have to double their charity care budgets. That's not happening without a fundamental system redesign. So if charity care doesn't catch people, what happens? Collections. And collections is where the system goes from bad to absolutely absurd. Here's how it works. When a patient can't pay their medical bill, the hospital eventually sells that debt to a collections agency, typically for 8 to 15 cents on the dollar. Let me repeat that. 8 to 15 cents on the dollar. So, if you owe $3,000, the hospital sells your debt for maybe $300. They write off the other $2,700 as bad debt. They've lost 90% of the bill value. The collections agency then pursues you. Phone calls, letters, threats of lawsuit, threats of wage garnishment. They report it to the credit bureaus. They add fees and interest. Now, some people do pay, under duress. Some negotiate a settlement, maybe 40 to 60% of the balance. And some never pay at all. They're too poor. They declare bankruptcy. But here's the math from the collections agency perspective. To collect on a $1,000 debt, their costs are purchase price from hospital, $80 to $120. Staff time for calls and letters, $140 to $180. Legal fees if they sue, $200 to $400. Credit reporting fees, $12 to $18. Total cost to collect, $432 to $718. If the patient settles for $600, the collections agency spent maybe $500 to collect it. They net $100. Many collections efforts barely break even or actually lose money. So let's look at this from every angle. From the hospital's perspective, they could have collected $3,000 if the patient paid. Instead, they sold the debt for $300. They spent $180 on billing and collections attempts. Net recovery, $120. They lost $2,880. That's 96% of the bill. From the patient's perspective, let's say they eventually pay. Original debt, $3,000. Collections fees added, $420. Interest, $240. Total paid, $3,660. Credit score drop, 67 points. Years to recover, 5 to 7. And here's the thing. The credit damage is the same whether you pay in full, negotiate a settlement, or never pay at all. Once it's reported to the credit bureaus, the damage is done. So the patient suffers massively. The hospital loses 96% of the bill value. The collections agency barely makes money. Who wins? Nobody. The system is generating lose-lose-lose outcomes for everyone. Here's what really gets me about all this. Prevention is cheaper than collection. Way cheaper. If an employer lowered their employee deductibles from $7,500 to $4,000, that would cost about $2,400 per employee per year in additional premiums. For a patient who would have incurred $3,800 in medical debt under the high deductible plan, preventing that debt costs $2,400. Prevention costs less and produces better outcomes. Better health outcomes because people seek care when they need it. Better financial outcomes because people don't get destroyed by debt. Better business outcomes because employees aren't stressed and leaving. Everybody wins with prevention. Everybody loses with collections. And yet here we are, in a system that defaults to collections. Let me give you a real example. Medford resident, family of 4. Household income $64,000. Employer insurance with a $7,500 deductible. Has an emergency appendectomy. Total bill $18,400. Insurance pays 0. Hasn't met the deductible. Week 2, patient calls hospital billing, asks about charity care. Told your income is too high, you won't qualify. Asks for a payment plan. Offered $770 a month for 24 months. Can't afford it. Week 6, debt sent to collections. Collections agency starts calling daily. Threatens lawsuit. Week 10, patient applies for charity care anyway because a friend told them to try. Gets denied. Income too high. But hospital offers 20% discount for paying in full within 30 days. So instead of $18,400, it's $14,720. Patient doesn't have $14,720. Week 12, collections lawsuit filed. Court judgment for $20,600 including fees. Wage garnishment ordered at $380 per month. Month 6, financial crisis. Between the garnishment, insurance premiums, and rent, the family can't make ends meet. They miss their mortgage payment. Credit score drops from 682 to 598. Month 9, files bankruptcy. Legal fees for bankruptcy, $2,400. Debt discharged. Credit destroyed for 7 to 10 years. Now, what could have prevented this? Option A, insurance with a $3,500 deductible instead of $7,500. Patient would owe $3,500. They could pay that over time. Cost to employer, $2,400 more per year in premiums. Option B, hospital charity care. Eligibility at 400% of poverty instead of 200%. Patient qualifies, 75% gets covered. Patient owes $4,600. Manageable. Cost to hospital, $13,800. But the hospital lost $18,400 through collections anyway. Same cost, better outcome. Option C, payment plan at the patient's actual capacity to pay. Patient can do $200 a month. Hospital accepts a 92-month payment plan. Total collected $18,400 over 7.7 years. Patient avoids collections and credit damage. Hospital gets 100% of the bill instead of 8%. Cost, 0. Actually makes more money. Every single option is cheaper and better than what actually happened, and yet the system defaulted to the worst possible outcome for everyone. Let me bring this back to where we started. Employers. You're already paying for your employees' medical debt, $500,000 a year for a typical 100-employee firm. What if instead of paying through dysfunction, you invested in prevention? Option 1. Lower your employee deductibles. Reduce family deductible from $7,500 to $4,000. Additional premium cost, $2,400 per employee per year. For 100 employees, $240,000. Your current hidden costs from medical debt, $512,736. Net savings, $272,736. That's a 53% return on investment. Option 2, Create a medical debt relief fund. Put $100,000 a year into a fund that pays off employee medical debt when it occurs. That covers about 26 employees with average debt of $3,800 each. Eliminates the debt, eliminates the cascade. Your current hidden costs, $512,736. Net savings, $412,736. That's a 413% ROI. Option 3, comprehensive approach. Lower deductibles, $240,000. Medical debt relief fund, $50,000. Enhanced employee assistance program with financial counseling, $12,000. Total investment, $302,000. Current hidden costs, $512,736. Net savings, $210,736. 70% ROI. Plus, improved employee health and well-being, stronger recruitment and retention, better employer brand, higher productivity and engagement. You're already paying for medical debt. The question is whether you want to keep paying into a broken system or invest in preventing the problem in the first place. So, here's where we are. Medical debt affects 1 in 5 households in Southern Oregon. It costs employers $500,000 per 100 employees. It costs hospitals 96% of the bill value. It costs patients their credit, their housing, their health. The systems we've built to manage unpaid medical bills, charity care, and collections are failing everyone. Charity care catches only 6% of eligible patients. Collections recovers pennies on the dollar while destroying lives. And the really maddening part? Prevention costs less than collection. Way less. And produces better outcomes for everyone. We know how to fix this. Lower deductibles, expand charity care eligibility, consolidate billing, create payment plans people can actually afford, forgive medical debt that's already in collections. These aren't theoretical solutions. They're working in other places right now. Spokane, Washington, Cleveland, Indianapolis. The question is whether we have the will to do it here. Next time, in our final episode, we're going to talk about exactly what those solutions look like, what works, what the evidence shows, and what employers, policymakers, hospitals, and individuals can do right now to start fixing this. Because medical debt is solvable, it's preventable, and the cost of prevention is a fraction of the cost of collection. We just have to choose it. This podcast is for educational purposes only, not medical advice. I might get details wrong. If you catch errors or have alternative perspectives, please comment. Subscribe to our newsletter at reimagine-healthcare.org. Thanks for listening.